Okay, so thank you for the kind introduction.
Good afternoon. At the outset, I would like to thank Fever Foundation for providing this opportunity to speak about asymptomatic bacteriuria. Before I start this topic, I would like to declare I have no conflict of interest or I have nothing to disclose. Coming to introduction, asymptomatic bacteriuria defined as the presence of bacteria in non-contaminated urine sample collected from patient without signs or symptoms related to urinary tract infection. Common finding in some healthy female population and in many women or men with abnormalities of genitourinary tract that impair voiding. Two criteria for diagnosis of this entity includes isolation of the same organism in two consecutive voided urine specimens for women and one voided urine specimen for men from a single urine specimen collected via urinary catheter in both sexes. Coming to colony forming units, it should be more than 10 to the power of 5 in a voided urine specimen. And most important point is they should not have any signs or symptoms attributable to urinary tract. That includes urgency, dysuria, frequency, and suprapubic pain or tenderness, renal angle pain or tenderness. Coming to magnitude of this problem. So it varies widely across different population subgroups. Coming to children, prevalence is very low. It is up to 1 to 2%. Coming to healthy women, in premenopausal age group, it is up to 5%. Pregnant women, it is up to 10%. In postmenopausal age group, it is up to 8.6%. And persons with diabetes, prevalence is more in women up to 16%. Men, it is around 11%. Elderly persons living in community, it is up to 16% in women and 19% in men. Elderly persons in long-term care facility, those patients may be having some disabilities, either physical or mental, for which they will be staying in nursing homes. Among this subpopulation, among women it is up to 50%, among men it is up to 50%. Patients with spinal cord injury, those who are on intermittent catheter use, it is up to 69%. Those who underwent sphincterotomy or condom catheter, it is around 57%. Persons who received kidney transplant in their first month of post-transplant, it is up to 25%. 1 month to 1 year, it is around 17%. More than 1 year, in prevalence definitely reduces, it is less than 10%. Persons on indwelling catheters, if they are on short-term catheter, that is less than 30 days duration, prevalence of this entity is around 5%, and long-term catheter prevalence almost touches 100%. Before discussing any topic, we must understand biology behind. So, sterile urine and collecting system are normal rather than exception. Question here is what breaches this sterility? And next question is why bacteriuria become asymptomatic in some and symptomatic in others. Bacteriuria, whether asymptomatic or symptomatic UTI, happens as a result of interaction of host, organism, and environmental factors. First, let us discuss bacterial factors that leads to development of this entity. Escherichia coli isolates from symptomatic UTI or asymptomatic UTI are definitely different from that resides in our gut flora. So these E. coli which cause UTI are called as uropathogenic E. coli. Reason for this development of uropathogenic strains are they develop certain mutations that impart the virulence factors, namely type 1 fimbriae, P fimbriae, hemolysin, and iron uptake system. However, those isolates which causes either symptomatic or asymptomatic infection showed similar genotypes. So at least at genetic level, whatever tests are available, we don't see any differences. However, when advanced genetic tests were done to see the function of these genes, we were able to pick up certain point mutations or minor deletions that can substantially alter the gene function. For example, a point mutation in PAP gene that render P fimbriae, which is very important virulent factor, incapable of adhering to normal urothelial targets. So current understanding is uropathogenic E. coli is not a commensal organism like similar to E. coli that resides in our gut flora. whereas it picked up certain adaptive genes for survival in the bladder, but was originally a pathogenic strain. We must remember that. And that lost its important virulence factor that results in the development of asymptomatic infections. The take-home message is there is no single gene that lend itself to a point of care testing to determine whether this bacteria that cause asymptomatic bacteriuria or symptomatic UTI. Maybe in future, we may develop certain tests that includes functional genomics like transcriptomics. They may provide us biomarkers to differentiate these two entities. And coming to host and environmental factors, certain polymorphisms in TLR4 promoter gene and chemokine ligand 8, which is also called IL-8, causes this asymptomatic bacteriuria. These observations can also explain by, in theory, that neutrophil activation. So unlike adaptive immune system, innate immune system is responsible for development of this entity. A large body of studies going on neutrophil activation. Probably we may get answers to why certain individuals develop this asymptomatic bacteriuria compared to symptomatic UTI in others. So probably it is too early to preclude. Probably in coming days, we may get some answers with respect to neutrophil activation mechanism. And other factor that contribute to asymptomatic UTI is bladder environment. Impaired bladder voiding and indwelling urinary devices such as bladder catheters as well. These are well-established risk factors for this entity. They both interfere with bladder's natural ability to flush out the pathogens. So to conclude, asymptomatic bacteriuria is not a single condition, but is different in patient groups with different underlying conditions. Important question here is whom to screen for this entity and whom to treat. So arguments for screening and treatment includes, it is presumed that asymptomatic bacteriuria may be precursor for future symptomatic UTI, which includes acute pyelonephritis. And it was thought that it may lead to CKD due to repeated infection resulting in renal scarring. Again, there are certain arguments against screening and treatment because screening, as we all aware, it leads to, if not properly chosen, it imparts excessive costs. And we all aware that unnecessary antibiotic use results in Clostridium difficile infection. Again, on society perspective, it can lead to development of multi-drug resistant bugs. So who needs screening and who needs treatment of this entity? There's several large body of evidence as well as Infectious Disease Society of America proposes that only two population subgroups unequivocally demonstrated to show benefits of screening as well as treatment. They include pregnant women and patients who are undergoing endourological procedures like cystoscopy, TURP, double J stent placement, etc. So we quickly run through these two subgroups. Like pregnant women, the story of asymptomatic bacteriuria started here. Kaas, in his seminal work in 1962, published that asymptomatic bacteriuria associated with increased risk of acute pyelonephritis and preterm delivery. Since then, there are several randomized control trials and observational studies demonstrated that asymptomatic bacteriuria in pregnant women associated with increased risk of acute pyelonephritis, preterm delivery, and intrauterine growth retardation. And treatment of this entity resulted in decrease in the incidence of these adverse events. And they stated that duration of therapy usually lasts 3 to 5 days. But however, single dose therapies were also tried with success. Again, there is uncertainty over the duration of treatment. And one thing we must understand that none of these trials evaluated long-term effects of asymptomatic bacteriuria, which were presumed to cause scarring. And none of these trials evaluated this problem. And we must also remember that all these studies which were published dates back to late 1960s and 1970s. We must understand that there is considerable progress happened in antenatal care in last few decades. So again, risk of preterm delivery and IUGR must be studied in current era to understand and to carefully subgroup patients who really benefit with treatment of this entity. Coming to urological procedure, there is robust evidence for treatment of asymptomatic bacteriuria before proceeding to any urological procedures. So, theory behind this is any urological procedure, especially cystoscopy, diagnostic or therapeutic, may result in breach in the mucosa. That definitely may result in invasion of these organisms into bloodstream, resulting in sepsis, and ascent of these organisms resulting in pyelonephritis post-procedure. So available evidence suggests that 3 to 5 days of treatment is needed before proceeding to surgery. And whatever evidence definitely demonstrate treatment of this entity results in the decrease in the incidence of sepsis and acute pyelonephritis. And again, single dose therapy was also studied with considerable success. And we really don't know the duration of therapy at this juncture. Definitely screening and treatment is recommended. And long-term outcomes, again, with like in pregnancy subgroup, long-term outcomes like renal scarring were not studied in any of these trials. So coming to other subpopulation groups where it deemed to be beneficial, and what evidence what evidence tell about treating or screening these entities. Coming to most important subgroup, what about pediatric population? We are all aware that pediatric population, they may not be able to clearly tell about symptoms and signs of UTI. Again, available evidence did not demonstrate any benefit of screening or treatment in this population. There is high quality of evidence to suggest that use of antibiotics in asymptomatic bacteriuria can result in harm, including increase in the cause and development of antibiotic resistance. However, we need to do future studies, not using all general pediatric population, probably some subgroups like children with certain disabilities of voiding, like neuromuscular disorders like spinal muscular atrophy and neurogenic bladder, and certain immune compromised states. Maybe that will give us clear understanding. Coming to non-pregnant women, evidence did not demonstrate any benefit, rather paradoxically increase in the incidence of symptomatic ATI in treatment groups. So higher incidence of antibiotic associated complications like Clostridium difficile infections were also noted in treatment group. Definitely in this subgroup, no screening or treatment recommended. So diabetics, very important subgroup. There is robust evidence against screening or treatment of asymptomatic bacteriuria in this group. And there is increased incidence similar to non-pregnant women, like symptomatic UTI following the treatment. So no screening or treatment required in diabetics. And we must remember that diabetic women have high prevalence of asymptomatic bacteriuria. Despite that, screening is not needed because treatment will not make any change, and rather it leads to development of resistance. And coming to elderly patients with impaired cognition, it is an important clinical dilemma for treating clinician. They will be brought to emergency with non-localizing syndromes like worsening of their prior sensorium or development of falls. Will you treat if you find asymptomatic bacteriuria in them? Clearly, there is paucity of evidence in this subpopulation. And coming to Infectious Disease Society of America recommends that in the absence of symptoms or signs of sepsis, these subpopulation needs careful evaluation rather than initiation of antimicrobial therapy. So definitely this subgroup needs further studies. Coming to non-urological surgeries that involves prosthetic implants, especially hip transplants or knee transplants or grafts in vascular surgery, etc. Available evidence did not favor screening or treatment of asymptomatic bacteriuria. Trials rather demonstrated more harm in treatment groups. So definitely no screening or treatment needed. Some miscellaneous conditions where there is evidence against screening and treatment of asymptomatic bacteriuria, like patients who are on short-term or long-term urinary catheters. As I told you, long-term urinary catheters, 100% definitely they will have asymptomatic bacteriuria. Definitely again, available evidence suggests there is no use of screening or treating those patients. Again, short-term catheters, prevalence increases as every day passes on them. But however, there is evidence against screening or treating. Coming to post-transplant, kidney transplant after 1 month, again, available evidence against screening or treatment of asymptomatic bacteriuria in this subgroup. And for any other solid organ transplant apart from the kidney, immediately after the post-transplant, if you find asymptomatic bacteriuria, there is definitely no rationale in treating that such patients. And even in post-transplant immediate 1 month, we don't have enough evidence. But again, fear of deleterious consequences on graft make nephrologists and transplant physician to treat those entities. Again, evidence, there is paucity of evidence in immediate post-transplant period. Coming to patients with spinal cord injury with voiding disturbances, in adults, definitely there is no evidence. Patients who are already on urological devices like stents and nephrostomy tubes, they may require treatment before the procedures. However, once procedure is done, stents are in place, there is no evidence to screen or treat asymptomatic bacteriuria in them. So most important part is magnitude of mismanagement of asymptomatic bacteriuria. This prevalence of this is pretty high, more common than asymptomatic bacteriuria itself. Here, there is a situation of clear evidence but muddled practice. Published studies reports about 20 to 50% over treatment of this entity. This, whatever studies I'm quoting are from Western data. We really don't have data from developing world. And it is the one of the significant contributor for antibiotic overuse. Why does overtreatment occur? So most important thing is lack of knowledge and fear of deleterious consequences. Despite the evidence suggests there are no deleterious consequences, still there is fear remains with treating physician. And we know that conventional teaching then and now is that bladder and urine within it are normally sterile. So we are finding non-sterile finding. So definitely it may lead us to treat this entity. And difficult to ignore. Once you do the culture, things will become even more difficult because sometimes in the presence of demanding patient, you may end treating that entity. Okay, when topic was given to me, when I quickly ran one cross-sectional survey among postgraduate students in our institution, almost 90% of them told that they do the cultures because they find pyuria in urine examination. Then when question was asked why they do urine testing, they said this is routine testing in any outpatient or inpatient setting. So the moment they find pyuria and they run the cultures, once cultures comes positive, irrespective of the symptoms, they may end up treating those entities. So we must resist ourselves. In the absence of symptoms, don't do the cultures and no treatment required except in pregnant or patients who are undergoing certain urological procedures. So to way forward in asymptomatic bacteriuria, we need biomarkers to identify asymptomatic bacteriuria versus symptomatic UTI, because relying on symptoms may not be easy in certain patient subgroups like patients who had cognitive impairment and children. And we need further studies focused on subgroup population where evidence is sparse, like as I already discussed, elderly with cognitive impairment. And we need further studies to optimize the duration of therapy in benefit group. Even in benefit groups like pregnant women and patients who are going to undergo urological procedure, we really don't know how long to treat them. And available evidence suggests that 3 to 5 days, and certain studies done even with single dose therapies. We really don't know exact duration of therapy. Maybe definitely it is shown that longer the duration of therapy, more the adverse effects. So we must minimize the duration of therapy. And we must also, future studies include renal endpoints like development of scarring that resulting in CKD. To conclude, asymptomatic bacteriuria needs screening and treatment only in pregnancy and prior to urological intervention. Magnitude of overtreatment is a serious concern both at individual level as well as on society. We need good biomarkers to differentiate asymptomatic bacteriuria from symptomatic UTI. So I will end my talk by this statement by Robert Atkins: don't fix what's not broken. Thank you.